I was actually interested in anorexia nervosa a lot when I was a resident. One reason was that my mentor at Children's Hospital was a child psychiatrist. I don't know what that had to do with my career, but Herb Needleman. Do you know Herb Needleman, Emily?
I don't.
And he was very interested. He was very interested in anorexia, and I got interested in what the chicken and what the egg was. And one of the reasons I was interested in it was when I learned that 50% of young women with anorexia nervosa lose their period before they lose weight. And that wasn't what I was expecting to hear. I was expecting to hear that they lost their period because they lost weight. And it made me sort of rethink what I was hearing about the impact of weight loss on generating the myriad of terrible physical problems that go with anorexia nervosa. So I think that this, oh, you're not seeing my screen? So let me go back, put the screen back up. So I think that it would be fair to say that we still don't have it all figured out, but it's a really important thing to know about. So it affects actually 0.5% of young women, and bulimia actually is even more common. It's 1 to 5%. And when you take together all the people with anorexia or nervosa or bulimia nervosa, about 5 or 10% are males, and they are often hard, we don't suspect them in the same way. So you have to be particularly, don't forget that males can be affected by this as well. They're often patients that because they show up for medical problems, but they're not coming in complaining about their anorexia. They're complaining about some of the things that go along with anorexia. In fact, they mostly don't even want you to know that they have it because they know darn well that you're likely to tell them that they should stop doing it, and they have their reasons for wanting to do it. So it's actually the third leading cause of chronic illness in adolescent females. So I didn't actually realize that, so that was an interesting thing. And sometimes you can first detect that they're having a problem with this because they get sick with something else, and then they come in to see you for mononucleosis or for a viral gastroenteritis, and they are so emaciated that it sort of throws them over the line to come and see you. But the morbidities that you see are due to, 1, starvation, and 2, the purging behaviors themselves. So those are the things to remember is that anorexia itself isn't sort of the cause of all the problem. It's the behaviors they do as part of their anorexia that ends up getting them in trouble. So being underweight and purging are the things that are dangerous. And this is actually an incredibly dangerous condition. So not only does it have high medical morbidity and functional impairment, but the mortality rate is as high as 20%. Anybody surprised about that? Kind of shocking, isn't it? And it actually has the highest mortality of any psychiatric condition. So the mortality is actually higher than it is for depression. And I gather, Emily, that it's higher than it is for suicide because of borderline personality disorder also.
Yeah.
So a third of the mortality is suicide. Can you comment on that? Go ahead. Sorry.
Yeah, I think part of the reason is that the mortality is so high has to do with the impact it has on so many organ systems, which is different from most other psychiatric areas of dysfunction. And I think that you get into secondary causes of death rather than the primary impact of the psychiatric illness. And so it just opens the doorway to so many other medical complications. And then because of the secrecy and typically the duration that patients will live with this, they don't come to care because they're used to feeling the way they feel, so that they die in their sleep.
Yes, and they die from cardiac causes. So there's the suicide cause, and then there's the cardiac cause. And I'm going to show you a whole bunch of slides about the medical conditions that do this. So it's something to be really worried about. And we'll talk a little bit more about why it's hard to worry about this. In fact, we'll start to talk about it now. And that is they deny they have an eating disorder. They try to hide their symptoms. They wear big, bulky sweatshirts. When they get weighed in, they put rocks in their pockets. They drink a lot of water before they get weighed. They're trying not to let people know how much weight they've actually lost. And they tend to be quite ambivalent about getting treatment, but they're also embarrassed and ashamed, and they're worried about the stigma of having this condition. So when they do come in, they're usually coming in, as we said before, for the complications. So this really means that we have to be really watchful for this because it's a sneaky condition. You know, when people come in and say, I think my kid has a certain condition, sometimes we spend a lot of time comforting the worried well, trying to get them to not worry. Well, in this case, sometimes we have to get them to worry when they weren't worried inherently. And that's why screening tools can be particularly valuable because, as you know, people tend to be more honest with screening tools than they are in an interview. And this would be a really classic situation where that's true.
I would also
add
that I just want to add, Barbara, I think working with parents can be complicated with these youngsters as well because sometimes moms may value the healthy lifestyle that their daughters typically may be seemingly too young. And so it can be a complicated thing to try to identify. Some of the moms may have dieting and other kinds of restrictive behaviors that maybe never tipped over or maybe did. And so maybe unintentionally facilitating some of the maladaptive approaches to food and health.
Yep. So when they start eating a lot of lettuce and jogging for 2 hours a day, they think that's a good thing, and the bad part of it can sneak up on you. The other thing I would mention is that 70% of girls with anorexia nervosa have a family history of anorexia nervosa, and it's actually about 60% of bulimics have a family history of bulimia. So the parents may have they may be in cahoots, or they may just be sort of in denial because they don't want their kid to have the same thing they had. I don't know. How do you think it works when you see a parent who's had anorexia and now has a kid with anorexia? Can you comment on that?
Yeah, I think it can go in a couple of different ways. One is that it can reactivate the parent's illness because it creates a sense of competition or other complicated psychological experiences that may trigger the same behaviors in the mom. So I think that's something to be mindful of. I think parents can go the opposite direction and get overly concerned before it's necessary. And then parents also may be alert to all the sneaky tricks that patients develop in trying to cover up their abnormal behaviors, and so they can become very strong allies. I think it can be a complicated conversation, though, because the kid's experience is, I am not my mother. Don't treat me as if I'm my mother. So they're delicate and very challenging family situations, and I think that kind of a family probably is best served by somebody with expertise in working with families with eating disorders.
Right. I would argue that most of these people need to be part of a team, partly because of how sneaky it is and how hard it is to tell if they're losing ground. But we'll get to that in a little bit. So I just wanted to sort of point out all the terrible things that can go wrong in anorexia. So in terms of metabolic problems, of course, rapid weight loss or weight gain is a problem in itself, but it can also cause electrolyte abnormalities. So the hypokalemia that can be very serious in terms of producing heart arrhythmias comes from self-induced vomiting, and especially if there's a low chloride and high bicarbonate levels as well. And laxative abuse can do this too and can also produce both metabolic acidosis or metabolic alkalosis. And diuretic abuse also occurs, again, can cause both hypokalemia and contraction alkalosis because they're basically dehydrated. They get hypoglycemic. They can be hyponatremic if they're over drinking water as a way of dealing with their thirst, because if you drink a lot of water, you're not as hungry, which is actually not a bad dieting trick for people who really want to diet who are not anorexic, but it also complicates weighing in. So if they could drink a couple of quarts, several liters of water, and that can give them water toxicity. They can also get hypophosphatemia, and that's very dangerous. So that's why giving phosphate as part of the treatment for acute anorexia in hospital anorexia is important, because they can get more hypophosphatemia when they're being refed. And then the next slide is about the gastrointestinal presentation, and that's what Emily was talking about in terms of how these kids can present as abdominal pain and constipation, or even irritable bowel syndrome symptoms that they get from the starvation or from the binging. They can cause themselves to have delayed gastric emptying and even gastroparesis, basically like paralyzed stomach, from the weird ways and amounts and kinds of things that they eat. And that is very often, in fact, it's more common than not, that they'll have GI complaints. And that's often the presenting complaint. Emily, do you want to add to that?
Yeah, it's interesting. I think the gastroparesis or the delayed gastric emptying are often huge hurdles in the recovery process, because patients feel horribly uncomfortable and sit there knowing that their stomach is filled with food. And so tolerating that sensation is a really an enormous barrier in the recovery process, much more so than a lot of the other side effects of refeeding. It's just something that the patients hate. They hate both the idea of it, but they also hate the physical sensation of that fullness, which is what they've strived to never have. So it is something to just make sure that families understand the importance of waiting that out, because it can take weeks to get through that.
Yep, and during that time, they're really they're very uncomfortable and complaining that they, and by the way, as you know, if you've ever been on a long diet or a fast, you can kind of get used to feeling empty, and so the feeling of having a full belly is really not comfortable at all in that situation. By the way, I've never had anorexia, if I sound like I'm making it too personal. Just for your information. So some other symptoms that are GI symptoms. They can
also get that superior vena cava syndrome. You're going to talk about that.
I'm going to talk about that. Yeah, exactly. In a minute. So the people who are inducing vomiting can have real gastroesophageal reflux disease. They can get tears of their esophagus, which can actually be life-threatening because they can bleed. You may be able to tell that they've been inducing vomiting because their parotid glands are enlarged. And some of the signs of induced vomiting include basically teeth that have been denuded of their enamel and have a lot of cavities. You can even see scars from their fingernails on their hard palate because they're sticking their fingers down their throat. And an absent gag reflex may be a sign of somebody who has been inducing vomiting, because basically eventually your gag reflex goes away, and these people can even make themselves throw up just without even sticking their fingers down their throat after a bit. This kind of thing can...
On their hands, you can see, usually on their first metacarpal joint, you can usually see either an open wound or some other kind of mark from where it's been in their mouth. They sometimes get a callus even.
Mm-hmm. And so those are things that on a physical exam on a random kid you might see, even if you are not seeing kids with weight loss. Those would be signs of kids who may be self-inducing vomiting, which is a lot more common than one might ever think, even before you're anorexic. But it can be the prelude to anorexia because it becomes a pernicious kind of habit. They can have elevated lipase and amylase because of the starvation. Here's the superior mesenteric artery syndrome can occur as part of being starved, basically, and they can also get rectal prolapse and hemorrhoids from chronic laxative abuse. Now, of course, you will see amenorrhea eventually in the girls, and even infertility. If they get pregnant, they don't do well being pregnant, and they get kids who have intrauterine growth retardation. They may continue vomiting during the pregnancy, and it's even been reported that people, after they've delivered a baby, try to get back down to their lower weight by pumping off too much milk. Seems a little odd, but there it is. We don't see adults, so I guess that hasn't come up. And then the neurological complications are really important because, again, this could be a presentation, but it's also a very dangerous sign. So anybody who's already having syncopal episodes and has significant orthostasis, those people belong in the hospital. So those are important signs. And so some of these kids will come in with syncope as their complaint. And as you're thinking about it, don't forget to think about eating disorders as part of that. They can also have other kinds of pain disorders, such as abdominal complaints we talked about, or headaches. But they can go on to have seizures from the hypoglycemia or from the water intoxication. And they can even get Wernicke-Korsakoff syndrome. So that is all really important. And then in terms of cardiac, I mentioned that this is one of the major reasons these kids die. So they can have very severe bradycardia, heart rates less than 30, and that then gives you QTC prolongation so that you're prone to arrest, and that's why they die in their sleep, is because the bradycardia is even more when you're asleep than it is during the day. They can get the cardiomyopathy from starvation and go into heart failure, and they can even get mitral valve prolapse because they have atrophic cardiac muscles. So it's the arrhythmias that get you, and if they add to that using something like an ephedrine diet suppressant or caffeine, that makes the arrhythmia even worse. So these are some of the most dangerous kinds of side effects. And then, of course, besides the amenorrhea, it changes your thyroid, so you'll have different thyroid labs. You can look like somebody who's hypothyroid with hair loss, with lanugo on the kid's back. I've seen plenty of that, and dry skin. And can even send you into ketoacidosis if it's a diabetic. Because of starvation associated with suppressing the bone marrow, you can see anemia, leukopenia, and thrombocytopenia, and it suppresses your immune response to infection, so they can get weird stuff like aspergillosis, which you wouldn't have expected. The renal failure is not a very common complication, but can come from laxative and diuretic abuse, as well as the contraction alkalosis from dehydration. Although you may see on labs, which you should get labs, you may see a very low BUN because they're not taking in enough protein. And you may even see a low creatinine clearance as well. And of course, the psychiatric problems that go along with anorexia include depression and anxiety and OCD and even substance use. This might be a good place, Emily, for you to mention how you've seen it present, or what would be clues that this is not plain old depression, it's something else.
So I think it can be very hard in patients who have pretty significant anorexia to distinguish whether they have something else going on, because in the starved state, a lot of symptoms of depression will be present. So fatigue, low energy, poor concentration, disrupted sleep. You can't really ask about appetite in these patients. But the state of starvation will produce many of those same symptoms. So for the severely anorexic patients, we kind of have to wait till they get to closer to a normal weight to sort of see what clears up with just refeeding. For patients, most bulimic patients are normal weight or slightly overweight. They tend not to be underweight the way the anorexic patients are. They are much more able to talk about their distress than patients with anorexia. There's a much higher rate of comorbid depression and anxiety disorders in patients who have bulimia, and also substance use. So depending on where you are in your differential, you may put the comorbid psychiatric illnesses higher on the list, But I think in a state of real starvation, we have to wait till they're not starved. It's like the old saying, when people have been hypothermic, and there's a concern that they may have died in the condition of hypothermia, they're not dead until they're warm and dead, because you want to make sure that you give the patient every chance to still be alive. And I think there's something about the starvation mode that we don't really intervene except to refeed and then see where we are.
That's actually really interesting in terms of thinking about depression itself. I've read some interesting things about how, from an evolutionary point of view, why is there depression? Like for us as a species, why do we have depression? It seems like it would be really bad to have depression if you're sort of in the native state of primordial man, right? And the hypothesis that was put forward is that it's a state that sort of saves energy, that it saves energy to be depressed. And it's interesting that in the starvation state, it looks like depression because, in fact, if you're starving, it's probably better not to be running around, right? It's probably better to be sitting still. I don't know. I thought that was a sort of an interesting thing. Can you talk, Emily, about how often kids who have an eating disorder have a history of trauma or sexual abuse? I realize that it's actually high in people with all kinds of psychiatric disorders, but what do you think about that connection?
You have to ask, but it's not my default go-to assumption. I think we have to be really careful about making assumptions that certain disorders have that in the history. I think we need to think about anorexia as a behavior disorder that needs to be interrupted. We need to understand what dimensional qualities a person may have that makes it easier for them to decompensate in that direction. We need to understand the genetics of the family history in terms of what they're at risk for, and we need to understand what life circumstances may have triggered the episode of it now. But I don't think we should draw a solid line between trauma history and anorexia. I just don't think that is supportable. It's much more likely that trauma is going to be presented as anxiety or depression than anorexia, unless you have somebody with dimensional vulnerabilities and a high genetic risk, in which case you should be worried about it anyway. So I would caution people about making assumptions about that backdrop. Or even if they have the backdrop, that's cause and effect.
Emily, could you comment more about OCD and anorexia? I find that hard to sort out sometimes.
So the underlying principle of OCD is the idea of intrusive thoughts that you cannot get out of your head. Classically, we talk about those as being unwanted. They feel intrusive. They feel inserted, and you don't want to be thinking about them, and they cause distress. So they may be thoughts about violence or sexual imagery or other kinds of obscenity-laden things that you're going to blurt something out in the middle of a religious ceremony of some sort, or they're violent images that are very, very upsetting. Now, for younger people, they may not have the same ego-dystonic experience with some of the thoughts. But patients who have anorexia do not experience any of their thoughts about their weight as ego-dystonic. And so they can feel very overvalued, almost delusional in their beliefs about themselves being fat. But at no point is it an unpleasant experience for them. It's a point of critical importance and pride and survival in their minds. So I think it is fundamentally different from obsessive compulsive disorder. They can have obsessive and compulsive behaviors around the rituals that they develop to support their egocentric beliefs that are almost delusional about their weight and body image. So they have to exercise 5 times, for 5 hours a day. That can seem like a compulsive behavior, but it's a different kind of compulsive purpose than an OCD compulsion has. An OCD compulsion is a behavior that temporarily reduces the buildup of distress. So the
That's
behavior
really beautiful. That's beautifully said. Yeah, that's really a great distinction.
That was very helpful. But are there not OCD individuals who get anorexia at a higher rate?
That's not something I'm specifically familiar with, Ray. That may be out in the literature, and that's my own ignorance.
Okay. No, that was
it's not something I've seen in my child experience at all. But so the other thing is you have to be careful about distinguishing OCPD, which are obsessive compulsive personality characteristics around perfectionism. That is not OCD. That is OCPD. Totally different. It may run in families and it has some overlaps, but they are really quite different in their nature and epidemiology and qualities of symptoms. So we do
is that a
see
DSM-5 diagnosis? I don't think.
Obsessive compulsive personality disorder?
Yeah.
The personality disorder has been around a long time. DSM-4 did not change. Going to DSM-5, the personality disorders did not change. And so we talk about OCPD traits, this perfectionism, need to control things, but that's very different. That's not really what OCD, obsessive compulsive disorder, is. OCPD is what drives us nuts when people are on committees and in meetings. Right?
So in other words, you can be high functioning in other ways and end up on committees.
It's a very reinforced, especially in medicine. We want to be conscientious and compulsive about what we do, and we want to get it right. I mean, it's a very rewarded quality. It's just when you get to the extreme tails of that trait, you're really irritating to other people.
Yeah. Well, does that have anything to do with autism? This is a totally off the mark kind of off the side kind of comment because I'm very, we are dealing with an awful lot of kids with autism who have very perseverative behaviors, and it always seems as though the behavior serves to comfort them in some ways because they can't manage the chaos of the normal world. But is there any connection?
Not that I'm aware of, no.
Really interesting. Maybe some place in a brain structure that we don't know. That's possible.
Yeah, I think okay. Go ahead.
Any questions so far? I'm going to talk a little bit next about sort of the diagnosis and initial workup for primary care. Anybody have anything they want to say first? Okay. So to make the diagnosis, when you're in full-blown anorexia, your weight is less than 15% of what it should be for your height percentile. And the fear of weight gain is an important feature of it. So these aren't people who say, I'd like to gain weight. These are people who say, I'm afraid I might gain weight. You need 3 months of amenorrhea in females. And when you see people and ask them, well, how much would you like to weigh, which is, by the way, a really good question. How much would you like to weigh? If they suggest a weight that is less than a BMI of 19, that suggests that they have the kind of mental structure of somebody with anorexia. So you should ask directly about the specific behaviors, such as what kind of dieting actions have they taken? Have they been binging? Have they been inducing vomiting or using laxatives or diuretics or pills for weight control? And also asking them and their family members about how much exercising they're doing, because they may lie to you about the fact that they're running 10 miles every day. And the family members may very well have been concerned about the amount of dieting they're doing and about the body image that they express at home. So that's another reason that lack of family meals is actually a risk factor in anorexia, because if you're eating with your family is going to notice what your bizarre eating habits are. But if you don't eat with your family, they may not have noticed that. So asking them, what would you like to weigh? Tell me what you eat each meal on a typical day and how much exercise you do daily are good questions. I already told you there's a family history of anorexia and bulimia, but the way these kids eat is to skip meals, to have a very limited number of foods they will eat, typically low-calorie foods, low-fat content foods. The people who are binging are eating high-calorie foods, but they're doing it with a sense of loss of control, often eating a huge amount of calories in a matter of 2 hours, and then trying to get it out of their bodies by inducing vomiting afterwards. Sometimes asking about the exercise, when you say, well, how much exercise do you get, asking them, how do you feel if you miss a workout? And if they panic, if they miss a workout, that can be a sign as well. And as Emily already said, this is a peculiar environment we're in right now because we're worrying so much about obesity that we think that people who are limiting their foods to low-calorie foods and exercising daily, that's a great thing to do, but it can slip in. So how do you figure that out? So I'm going to just show you some samples of 3 different screening tools that might be used to screen, particularly adolescents. One of them is called the SCOFF. So here is the SCOFF. It's 5 questions, and if you have 2 or more yes answers, that is a positive with a very high prediction for anorexia. So do you, SCOFF, do you make yourself sick because you feel uncomfortably full? Do you worry that you've lost control over how much you eat? That's the C. Have you recently lost more than 1 stone? Sounds a little tough because it was a British tool. 14 pounds in 3 months. Do you believe yourself to be fat when others say you're thin? And would you say that food dominates your life? So sick, control, 1 stone, fat, and food is the sort of mnemonic for it. These are all in Chattis, by the way. The PHQA, which is actually one of the most useful teenage self-report tools, does include a whole section on symptoms that might be eating disorders, and that's on this slide here. So it's the same sorts of things. It asks about height and weight, and then asks if you think you're too heavy, how much you worry about it, how much does it control how you feel about yourself, and then specific things you might have done in the last 3 months to either lose weight or avoid gaining weight, as well as your menstrual period. So this is actually quite a complete inventory for anorexia nervosa, and it's included in a tool that asks about depression, anxiety, and substance use as well. So it's great because those are the biggies for teenagers. And then there's a more detailed tool called the Eating Attitudes Test 26, which has quite a few questions as well. I'm just showing you on this slide what the conclusions look like. But it, again, talks about symptoms, exercising, vomiting, desired BMI, and gives you a risk score for both either anorexia or bulimia. So those are all tools that you might consider using. There was an interesting survey of physicians who were doing screening tools for teens, and by and large the screening tools did not include enough items about specific symptoms of eating disorders to help you as much as you might need. And again, teenagers are more self-revealing on questionnaires than they are in person. I already told you what the SCOFF was. So here are some of the bad things that it could be instead of anorexia, like brain tumors, malignancies, GI malabsorption or celiac disease, endocrine disorders, depression, or superior mesenteric artery syndrome for another reason. The list isn't actually that long. The trouble is that they may actually look like they have one of those other things as well, so there may be some workup that you need to do to figure that out. But the basic primary care workup would be, first of all, history, right? But then if you're going to collect labs, it would be a CBC, electrolytes, liver enzymes, a urine, and a thyroid stimulating hormone. If they don't have periods, then you may be doing your basic amenorrhea workup with LH, FSH, pregnancy test, prolactin, and estradiol. If they're already sick enough, so that they've got bradycardia or abnormal electrolytes, then you definitely need an EKG. And actually, I think the EKG can start to get people serious about the condition. So in other words, the teenager and the family gets more serious when they see you put them out there and do an EKG and say, you know, one of the problems with this condition is that you can die. That really sort of gets their attention. And in chronic management, you may need a bone density. You don't need brain MRI unless you have already got other reasons to think that there might be a brain tumor, for example. So these are the AAP criteria for hospitalization for anorexia. Weight loss less than 75% of what should be the weight for height, low heart rate, low blood pressure, orthostatic changes, low temperature, or the presence of arrhythmias. And in the case of bulimia, if you see electrolyte imbalance, syncope, hematemesis, probably from a Mallory-Weiss esophagus, intractable vomiting, or tears, those would be reasons to put a bulimic in the hospital. And the regimens for refeeding include sometimes NG tubes and IVs, but has to be done very delicately. So it turns out that most people can get over these problems if it's dealt with well, particularly if it's dealt with early. But if they end up in the hospital, they may already have impaired their long-term cardiac growth, bone, or brain development. So that's a big, scary thing. So people are often discouraged about being able to stop these behaviors, but giving them hope is really important and getting the family involved. If you're going to be managing kids as outpatients, the goal is going to be 2,000 to 3,000 calories per day with a weight gain between half a pound and 2 pounds a week, but you've got to get them back over and over and over again, at least every 3 weeks. Weigh them without letting them see it and make sure they're being weighed basically naked in a gown. Otherwise, they may have stashed stuff to make it look like they've gained weight. But I think a multidisciplinary team is in order sooner rather than later. And we're really lucky here in Baltimore because we've got a number of places. Hopkins and Shepherd Pratt are very interested in eating disorders and prepared to work with you to work on that. Emily, do you want to comment on any of those things about treatment or what resources you like to refer people to?
I think, the Shepherd program has both inpatient and outpatient and day hospital, and as does the Hopkins program. I think it is really important. Sometimes these kids will get an NG tube to try to get them refed, and I think in general the guidelines, there's nothing wrong with their GI tract, and part of what we need to help them tolerate and get back in the habit of is putting food in their mouth, chewing it, swallowing it, and leaving it there. And so unless their GI tract does not work, they have an significant absorption problem, we really encourage people to make these patients use the GI tract that they have rather than giving them an NG tube in some way. Although I think it can happen because they aren't very cooperative in eating. And so what will happen on the unit is that staff will sit with them. If it takes them 6 hours to eat their breakfast, it takes them 6 hours. But they don't get off the hook. And I think part of the challenge is for families how to create the kind of supervision and the kind of structure and the kind of behavioral programming at home that they can have in an intensive program. And so that's partly why the programs can be very helpful to kickstart the care. But it is a kind of, I would say, a lifelong issue for many, many patients because food and dieting is everywhere, and temptations are everywhere, and people have opinions about food, and weight is very much part of the common discourse. And so there are many things that will keep it alive in the way that if you have an addict who, gives up heroin, can create a different kind of social community that doesn't use heroin. But everybody eats. And so it can be very challenging. And part of the work is to help renegotiate those relationships with food and eating and restaurants and things like that.